Thank you for the kind introduction. Good afternoon, everyone. Indeed, thanks for the opportunity for me to share with you all about this risk assessment and management program of Hong Kong. Right, so when you all hear the word RAM, I think for those who work in the public sector in Hong Kong, you are probably very familiar with this word. But for those who hear it the first time, maybe you could really imagine that as a real RAM that through which diabetic patients can slow down their complications rates as well as their ABC parameters. So exactly how much that can slow down, I'll tell you in a minute later. Just before I go into the details of RAM, I would just like to give you some brief background about the primary care system in Hong Kong. Well, the care is provided by both the private sector and the public sector. Like what Dr. Tandon in India, also in our setting, private sector provides about 2/3 of the total outpatient doctor consultations, while 1/3 in the public sector. And in the public sector, it's mainly provided by Department of Health and Hospital Authority. And within Hospital Authority, it is really the general outpatient clinics that provides the primary care, and that's also where I'm working in. In Hong Kong, there are 74 general outpatient clinics across the whole 7 clusters, and each year we provide more than 5 million attendances to the public. And among those chronic illness that we see in general outpatient clinics, diabetes is actually our 3rd most common chronic illness, attributing to about 20% of our total attendances. And so exactly how many diabetic patients are we managing right now? So back to 2009, we are managing around 165,000 diabetic patients. And over the last 12 years, it has already doubled to 336,000. And the yearly increment is about 4 to 6%. And according to the Population Health Survey that was just released last year, the total prevalence of diabetes is about 8.5% among those aged 15 to 84. So if you do a little bit of calculations, you can figure out that the GOPC are actually managing about 50% of the diabetic patients in Hong Kong. And another 30% is actually being managed in the hospital settings. And that leaves about 20% of the diabetic patients in the private sector, or maybe they're not yet diagnosed. And this is the slide extracted from the primary healthcare blueprint released last year. For a diabetic patient or hypertensive patient with cardiovascular disease or CKD, their annual cost per patient is about 2 to 3 times higher than one without complications. So we know that it is really important for us to try to reduce the complications of diabetic patients as well as to control their ABCs. And so these are also the 2 important strategies that we try to do in our outpatient settings. And that's also the start of our RAM program. And thanks to the support from the government, we had some funding since 2009. And also thanks to Professor Chan's the previous JADE model, that's how the RAM program started. It is a structured program, and we aim to recruit all those diabetic patients that are being seen in GOPCs. And through the program, we detect their complications rates. And then after that, we try to give them appropriate management so that we can reduce the further severity of their complications. And when it first started in 2009, it started across the whole 7 clusters in our 74 outpatient clinics. And so what do we actually do in this RAM program? I would say there are 4 main features. Well, definitely there's a standardized assessment that guide healthcare providers what to do. And then there's a risk stratification. And through that, we have a multidisciplinary approach to provide care. And for each patient who have different risk level, we try to give them tailor-made management. And for the assessment, when they first come to our clinic, we have our patient healthcare assistant to, of course, do the basic parameters measurement, like measuring their body weight and height, BMI, check the blood pressure. We also provide laboratory tests like all the cholesterol level, renal function, A1C, and also the urine test for albumin-creatinine ratio. And we also have our advanced nurse practitioner to check for neuropathy, and also to check the peripheral pulses to look at for any foot ulcers. And we also have optometrists to check the fundus, to use the fundus camera to look for any retinopathy. And after we have done the assessment, we collected data from the history, from all the assessments, and we input those data into our electronic system that we've been using in hospital authority. That is the clinical management system. And this is the model that we followed from JADE program. With the history, the different risk levels, then we stratify them into low risk, medium, high, or very high risk. And for each different risk level, we then provide different management. If they are just having low to medium risk, they will just be managed by their own doctor in GOPCs. And the doctor will basically look at the results and adjust medications accordingly. But if they have high to very high risk, they will be managed by both the advanced nurse practitioner, who would give them more intensive education and advice, help them, give them advice on lifestyle modifications. And they will also be seen by our senior doctors, AC or consultant, who would give them more intensified drug treatment. And here I just quickly mention that for, well, we have 7 clusters altogether. In my cluster in New Territory East, we provide about 15,000 REMS every year. So for all clusters together, each year we provide about 100,000 REMS. And just now I mentioned that we have about 330,000 diabetic patients. So each DM patients probably get REMS every 2 to 3 years. And in terms of drug management, well, back to 20 years ago, we only had 2 medications for diabetes, just the metformin and sulfonylurea, which is the glycoside. And over the last 20 years, we really have added a lot of drugs to improve the management, and that includes statin and also the RAS inhibitors as well. And last 1 to 2 years, we also added SGLT2 inhibitors. And for the cholesterol side, we just added aciptamab just a year ago. And so hopefully with all these enhancements in drug treatment, we can further improve the ABC controls of our diabetic patients. And the fourth important point of this program is that we have a multidisciplinary team to manage our patients. Apart from the RAM team, the doctor and the nurse, the optometrist, we also have very good support from our allied health staff. If they are found to have poor diabetic control, also obesity, we will refer them to see the dietitian. And at the moment, we're reviewing the RAM manual, and we are planning to also refer those with poor EGFR. If they have EGFR less than 45, we are thinking that maybe it's a good time to refer them to see the dietitian as well. And if they have feet problems, skin problems, we will also refer them to see the podiatrist. And also, again, for obesity, we will refer them to see our physiotherapist for weight reduction. And apart from the allied health support, we also have other community resources support, like the patient empowerment program. And for the patient support call center, it is a group of nurses run at the headquarter level. And what they do is, at the back end, they will retrieve patients with poor diabetic control, and they will give patients calls to ask them how they are with the medications and ask them if they have any difficulties in managing the conditions. If they do find that these patients have problems in taking medications, very poor control, they can refer back to the patient's own clinic. They will inform the doctor there, and so that they could see the patients earlier. And of course, if they are smoking, we will refer them to see our smoking cessation counselor. And if they have wound, we will also refer them to see our wound specialist. And for the patient empowerment program, since about 4 years ago, we have this district health center that's run by the government. It started the first one in Kwai Ting, and now for each district in Hong Kong, there are 18 districts. Each district will have 1 district health center. And so for patients who have diabetes, if they want additional advice or lifestyle modifications, exercise program, they can actually attend these centers for more information and help. So after running the RAM program for nearly 14 years, where are we now? How are we doing? It is important to find out how many complications we have detected. Are we giving adequate or early interventions? And also it is important to find out, are we actually reducing complications? And so let's have a look at some data. This is the data from the Hospital Authority, and as of 2021, I'm just looking at the GOPC patients. That's about 300,000 patients, and for these patients, majority of them have their smoking status being checked, but only about 70% have their BMI recorded. So there's still some more room for improvement. And for those laboratory tests, I would say more than 90% have yearly tests for the A1C, the cholesterol level, renal function, but only about 75% have urine albumin checked. So again, there's still some more room to improve for that aspect. And because we do RAM every 2 to 3 years for our diabetic patients, and so for the eye exam and foot exam, we check the intervals every 3 years. And for eye exam, only about 77% have it checked. And on the foot examination, about 67% have it checked every 3 years. So, I mean, maybe the interval of RAM is not as frequent as it was before. So now, maybe there's still some more room for improvement for those two aspects. And in terms of complication rates, as of 2021, we found that about 7% of our diabetic patients have coronary heart disease, and half of that, about 3.7%, have stroke. But 1/3 of our patients have microvascular disease like nephropathy and retinopathy. And for nephropathy, here we are referring to patients who have positive results for microalbuminuria and or macroalbuminuria. And for the ABC control, I'm looking at the last 5 years' results. Well, for the diabetes side, it is slowly improving from 59% to 62% with optimal control. And I remember when we first started our RAM, that was like 2009, the result, the control was, of course, much lower. Only it was below 50%. And for the blood pressure side, is around 80% to 78%, which has been static for the last few years. And for the cholesterol level improvement, it was from 67% to about 74%, again, slowly improving. And hopefully with the drug enhancement that we have just added, the aciptamab, hopefully we could have better control the cholesterol level. And for the GFR staging, and from the results that we recorded from the computer system, about 13% have G3A to G5. So majority are within the OK range. And then I also looked at the drug treatment in my cluster, whether we have given them adequate treatment once we found out that they have complications. I look at the patients that had RAM in my cluster in 2022, about 15,000 diabetic patients. Well, among those with coronary heart disease and stroke, about 80% or more have been given aspirin, and about 90% have been given statin. So again, there's still some more room for improvement, not yet 100% receiving adequate treatment. And for the same amount of, same number of patients, I also look at how many have microalbuminuria or macroalbuminuria, and whether they've been given RAS inhibitors. And it is noted that in the microalbuminuria group, about 76% have been given appropriate treatment, and in the macroalbuminuria group, only 86% have been given RAS. Again, not exactly reaching the optimal side yet, but still more room to improve. And in terms of the overall RAM program, thanks to both teams from Hong Kong University and Chinese University of Hong Kong, they've done quite a few evaluations on our program. So this is the very first evaluation that was done about 19 months after RAM program has been started. Hong Kong U looked at the quality of care, the structure, process, and outcome. And at that time, they found that the structure was well planned with clear objectives. And for the process, well, about 97% were given a risk level, were given a stratification. And for the outcome, that was only 6 months after RAM. About 2/3 felt that they were more enabled. And 1 year after RAM, we see that ABC controls have all improved. And also the Chinese university had evaluated on the stakeholder side, and they were given, both patients and service providers were given questionnaires to see if they are satisfied or, and see how they rated the program. From the patient side, they look at the accessibility of service, communications, quality of care, interpersonal aspect of care, and also health improvement and protection. And about 96% responded that they rated highly on the clinics that they attended. And on the service provider side, that include the nurses, the doctors, and also the allied health staff, 80% said that they were satisfied with the program. And about 95% agree that the RAM program are giving comprehensive care for the patients. So it seems that the results are very positive at that time. And how about the effects of the program after we've been running it for 14 years? This is a population-based cohort study that was done by the Hong Kong University of Hong Kong, and the results was just published last year. They followed up the patients for nearly 10 years. They basically look at the patients in two groups. One is the RAM group, that's they have RAM every 2 to 3 years. And the other group is just usual care, that they didn't have any RAM, but they have been being followed up regularly by our case doctors. And then they look at the cumulative incidence and incidence rates for complications and all-cause mortality. And so let's see what they found. Well, on the ABC control, the RAM group have shown improvements in A1C control, blood pressure, and cholesterol level. And the results were still significant at year 9. But then at 10 years, it seems that only the blood pressure control has shown significantly improvement. And for the complication side, we look at the macrovascular and also the microvascular complications. And it's very obvious that the RAM group has reduced the complications in both of the sides. For the macrovascular, complications rate is 27, while the usual group is 39. And in the end-stage renal failure, the rate, it was 4.3% in the RAM group, but it was 7.5% in the usual group. And if we look at the hazard ratios of all these complications, it shows that it has about 30 to 50% reduction in all these different complications. And for the all-cause mortality, there's a 50% reduction. So it's all these evaluations are showing that the RAM program can effectively help to reduce the complications. And how about the cost effectiveness? You probably think, oh, we have put a lot of resources on this program. Is it really cost effective? And there's a cost effectiveness study that was done 5 years after the RAM program has started. And you can see that the middle column, the usual care group, for a 5 years course is about $19,500 US, while the RAM group is about $12,010. If you added the program cost itself, which is about $157, it is still $7,000 cheaper than the usual group. So this 5 years cost-effective analysis has shown that RAM program, not only is it effective in reducing complications, it is also very cost-effective. So in summary, we all know that diabetes is a global disease causing multiple complications. In our setting in Hong Kong, we know that RAM-DM is a very cost-effective program that is helping the diabetic patients. But we are all facing the same challenge that with the population aging, the number of diabetic patients is rapidly increasing. And with the same resources, how can we cover adequately for our diabetic patients? We need to expand the resources so that we can keep the program effective and sustainable. So that's the end of my presentation, and hope you all enjoy the nice view of the sunset. And just could I quickly ask you, if you have time, maybe a couple of minutes, could you help to answer the survey so that it helps to collect your views on the role of primary care physicians on the management of CKD and diabetes. And your views will be very available for our future discussions and planning. Thanks a lot.